Good afternoon, everyone. It's May 14th, and you have joined the Innovation Workgroup. I'm Kimberly Hendricks. I'm your chair, and I'd like to welcome you to this meeting. I'll check and see. I know that Sean Parkman is not going to be in attendance today, but we have Robert Young. Yes. and then Sally Duerfelt.
Yes.
Welcome, and you're a new member for us, and we'd like to welcome you.
Thank
And I will
you.
go ahead and turn this over to Margaret.
Yeah, thank you so much, Kimberly. First off, I want to note I'm really glad we were able to get this meeting on the calendar. We had really been aiming to reconvene the Innovation Work Group this spring, and with a very, very busy spring season with renewals and all the work both of the boards have been engaged in, calendars proved a little challenging. So really glad that we're able to convene today. To start off the meeting, I'm going to walk through a quick overview and just kind of a brief recap of Innovation Workgroup purpose and goals and work to date at a very high level. I'll also share a very high level draft work plan that we are fleshing out for the remainder of 2025 and 2026. And we'll talk a little bit more about that when we get to that point. So Rose, if you could advance to the next slide. Oh, and you can go one more. Great. So as said, welcome back. I want to note our current membership for the Innovation Work Group. We have had some new additions and departures from the work group since the last time the work group convened last spring, almost a whole year ago. Starting off, as Kimberly already has said, I want to welcome Sally Duerfelt from OEB as the newest member of the work group. And then Robert Young, along with Sally representing OEB. And then for PEB, Kimberly Hendricks is the work group chair, and Sean Parkman also participates in the work group on behalf of PEB, and unfortunately could not be here today due to a training. So thanks everyone for being in attendance and welcome back. I think we're really looking forward to kind of reconvening this work group and reaffirming the work group's charge and the work ahead. Next slide. So just really quickly, today's meeting, as I mentioned, we'll briefly recap IW history and goals. We'll look at a really high-level draft work plan. And then we'll have some pretty detailed data presentations provided by Mercer, particularly kind of high level understanding why Medicare is used as a benchmark when we look at provider payment data. And then looking at some pretty detailed analyses Mercer has been working on this spring. One specifically looking at review of the OEB and PEB hospital payment cap. That provision in statute that caps payments for inpatient and outpatient services at 200% of Medicare for non-exempt hospitals, specifically capping at the larger DRG hospitals in the state. And then also a further review of data looking at level of payments. So looking at what OEB and PEB payments are averaging across service categories relative to what Medicare would pay for those services. Next slide. So in terms of recapping, a little historical recap. Senate Bill 1067, which was passed in the 2017 session, directed the Oregon Educators Benefit Board and the Public Employees Benefit Board to create a joint executive committee that would work on developing a plan to combine the functions and operations of the two boards, aiming to get efficiencies. That executive committee met for a period of time and ultimately produced a report or recommendations. And one of their main recommendations aimed at really getting synergies and efficiencies between OEB and PEB was to form an innovation work group. And the direction from that committee was that the work group would explore innovative solutions to achieve sustainable, cost-contained benefit programs. So the Innovation Work Group launched in fall of 2018 with joint membership of OEB and PEB boards, and has been in existence ever since. Has had, over the years, various board members have served on the work group, and it's looked at various different topics where there's opportunities to leverage OEB and PEB jointly. And that has brought us to today. So if you could move to the next slide, Rose. In terms of some of the work that has happened over the past several years of the work group's efforts, there's been a range of topics that have been part of the work group's portfolio. Those include implementing and monitoring the hospital payment cap on OEB and PEB hospital payments. That included developing the rules that govern the administration of that payment cap, the public rulemaking process, monitoring and evaluating implementation of the cap and subsequent updates to the rules, and looking at savings achieved through that initiative in the first couple of years that it was in place. Also, an ongoing topic for the work group is looking at level of payment across healthcare service categories, and we'll review that again today, updated data in terms of looking at when we talk about Medicare as a benchmark, where are health plan payments for services for PEB and OEB members. The work group has also done pretty extensive work on performance guarantees that are included in medical plan contracts, and I think that's an area that continues to evolve over time and is certainly an opportunity for future work for the work group as well. The work group also did a lot of research and analysis on centers of excellence models, specifically focused on joint replacement surgeries as a candidate. And I think although there has not been sort of a formal proposed model to move forward out of this work yet, as we look at implementation of Garner in the new benefit plan year, that is a movement in that direction in terms of identifying high-performing networks of providers and incentivizing use of those providers. And then the work group has also on an ongoing basis, monitored carrier progress on adoption of value-based payment methodologies, and has done some pretty extensive work looking at the lay of the land in terms of behavioral health network access and adequacy measuring. And last spring, developed specific metrics, behavioral health network adequacy and access metrics that we added to our medical plan contracts to get a better consistent year-over-year reporting of how access is looking. Next slide. The Innovation Work Group has articulated, a collection of goals, and this information, part of the meeting packet also included, for your information and review, the work group's current charter. That charter was last reviewed and updated by the work group about 2 years ago. It was late winter of 2023. And so I do think then we aren't going to spend a lot of time on it today, but I think that when we get into the fall, it is certainly within the work group's domain to consider whether or not you want to make any updates or further expansions on that charter in terms of the content that's in there. So consider the copy in your packet today, just sort of information for you to review and consider at this point. And it's quite likely as we get into the fall, something that we will look at in a little more detail. But from the charter, some of the main areas of goals that the work group has identified revolve around these four major areas you see here on the slide. So quality, specifically focusing on initiatives that can improve quality, and then monitoring indicators of performance on those initiatives. Also access and equity. The work group has articulated a particular interest in examining how initiatives explored impact, quality, access, and experience of prioritized populations. And you can see those prioritized populations listed there on the slide. Those were articulated in the work group's charter. Sustainable cost is also a significant area of work group focus, specifically identifying options and strategies to help the boards meet the 3.4% annual cost growth cap and to stay within that limit. Along with that, prioritizing the initiatives that have the greatest potential to recognize some of that benefit, and leveraging OEB and PEB data and the collective covered lives to the maximum potential possible. Sort of that idea that with larger numbers are where are the opportunities to see more opportunity in terms of achieving those outcomes. The work group has also articulated really wanting to work on shared incentives for carriers and providers to control cost, and as noted previously, expansion of value-based payment approaches. And then one of the other final main areas where the work group has articulated goals is in the area of partnership, specifically aligning with other OHA initiatives as feasible, obviously seeking input from the OEB and PEB boards. That is an area I think where the work group has in the past really looked to the boards to help identify priorities and help define areas of focus. The work group recognizes itself as a forum to really direct research and consult with experts when working on various initiatives prioritized. And then also the work group has expressed a desire to inform legislative solutions and approaches as appropriate when those arise. Next slide. So looking ahead for the work group, and again, it's been a while, so I think we want to spend some time getting grounded and kind of fleshing out where we focus in the months to come. We are proposing that, and this is all draft, so I want to preface this by saying we're certainly seeking input, both from work group members and the board as a whole. Our general thinking is that the work group will move forward with an every other month meeting schedule beginning in fall 2025, beginning in September. Generally speaking, we would look to have meetings to be about 2.5 hours for each of those meetings. And I do want to note, that standing meeting schedule, I think we always want to acknowledge that it can be reassessed as needed, and the work group can opt to add meetings to the schedule as well if particular initiatives require. I think we want to be mindful of balancing the need to have this group convene with some regularity and relative frequency to make progress and to flesh out some of these complex initiatives. We'll also be being very mindful of the time commitment and the resource requirements involved. So that kind of highlights what we're proposing as a general schedule moving ahead. And again, certainly interested in any feedback or thoughts work group members have. As you can see in the data table kind of laid out for today's meeting, we have the topics previously acknowledged around the hospital payment cap and level of payment analysis. June through August, we are not planning to schedule meetings. And then we would reconvene in September. Draft topics flagged for the upcoming meetings include review of the charter, possible updates, and identification of focus areas. We will be due for a progress check on how value-based payments are progressing in our plans. As we get a little bit later into the fall, we will need to, this work group has generally been the forum for review of carrier performance on the cost and premium trend guarantees that are in our medical contracts. And then also looking further ahead, again, meeting dates to be determined. But I think we are definitely want to focus in 26 on leveraging purchasing power, sustainable payment models, refining performance guarantees and targets, continued monitoring of payment levels and the hospital cap, and also a very important one, we want to develop a structure for review and monitoring of Garner, the new member steerage program. So I'll pause there. Sally, I see your hand is up.
Yeah, the November meeting where it says carrier cost trend premium guarantee performance review, or is that the 3.4%? Okay.
Yes. Yeah. And it would be looking at, we would be basically looking at final reconciliation and review of that performance for OEBS 23-24 and for PEBS 2024 contracts. So determining, for those contract years, was the guarantee met? If it wasn't, how much was the 3.4 cap exceeded by, and then sort of what sort of fees at risk are involved with that reconciliation.
Yeah, that's one thing that definitely has my curiosity piqued. And I don't know, you can let me know if this group really discusses that, to look at whether or not that 3.4% is really outdated, considering inflation, cost of goods, things like that, at what point in time do we review that and pursue legislative change to increase that percent, so that there is not as much sacrifice on plan richness, right? Plan coverage, in order to get down to that 3.4% every year. It typically results in a trade, right? As you know, of what a plan covers. We sacrifice some on that end to bring the premium cost down. And is that 3.4% really sustainable anymore, without every year after year really cutting back on what a plan covers in order to meet that? So
Yeah. Thank you for that, those thoughts. And it's always good to hear when particular topics are of great interest. When we do that review, we always sort of look at like what has market trend been, and how does PEB and OEB compare to what's going on in the broader market, and what we see in those other segments. So it's certainly part of the discussion. And yeah, I mean, I think there's certainly space for the work group to discuss, strategies or approaches or ideas around that particular issue. So we'll definitely be making space for that in the fall.
Margaret, I have a question. It's more general.
Sure.
So I'm trying to track in my head what the different focus for IWG as opposed to COUT. And case in point, the November agenda, I would have thought that would have been more of a COUT topic, so I'm not getting this right.
Yeah, no, it's a really good question, Robert. And I will tell you, we talk about that a lot as staff, and Glenn and I regularly huddle to figure out which topics kind of go where. For the particular performance guarantee review, historically, what we've aimed to do is have the innovation work group be the space specifically for the cost trend guarantee, and then COW is the space for the clinical quality guarantee and those measures. So we have multiple guarantees in the medical contracts, and I mean, this is a really rough division, but I guess a little bit you could sort of think COW sort of focuses more on, leans more on kind of quality and those types of indicators, and the innovation work group focuses a little more on the sustainable cost. Where are we actually spending? What do our payments actually look like? So that kind of helps provide some kind of who's in which lane. There is some overlap though, and I do think we sometimes have topics that could kind of go in either camp. And so we certainly have conversations about that, and I think are interested in work group member input as well. If work groups have a strong feeling in either CR or IW that one group or the other should handle something, or take ownership of a topic, that's absolutely can be, the work plans can reflect that.
Clarify things for me. Thank you.
Yeah, you're welcome. So in terms of scheduling meetings looking ahead, we will work on this offline. I will be reaching out to work group members with another doodle poll with proposed dates and times, and we'll work through that process and find an option that aligns with calendars. So thank you in advance for your patience with those polls. I definitely try to make them as streamlined as possible, so you aren't answering too many questions about your availability, but we will begin that process soon, so we have things calendared for fall and the months ahead. And next slide, Rose. I think, yep, that's the last slide in this particular update. So I'll pause for just a second for any other questions before I hand it back to Kimberly, who I think will then hand it over to Mercer. Great. All right. Well, thanks so much, everyone. And as always, if you think of a question after the fact, please just reach out to me. I'm happy to connect offline as needed on any of those logistical or other questions.
Thank you so much, Margaret. I love that you're such a historian and you know all this work that we've been doing. And it looks like next up we have Emery from Mercer is going to lead us into the next section. Thank you, Emery.
Thank you, Kimberly. Thanks. So we have a couple of, I guess, related but actually different presentations kind of mashed up into one. So if we move on. Thanks. Let's go to and here on the agenda. So we do have two different essentially reports, but they will be kind of very similar information being provided. This is really comparisons of costs versus Medicare. So as Margaret mentioned, one of the reports or the one of the things required from the Senate Bill 1067 is to look at the payment levels in terms of whether the hospitals or the plans are meeting payments for the hospitals based on the DRG facilities at 200% of Medicare. And so that is going to be the first portion of this report. The second portion of the report takes a look at essentially all of the services excluding pharmacy and their relationship to percent of Medicare based on reporting from the plans. So the data is going to be very similar between the two, although they are a little bit different because they are from different sources, and we'll go over that in a little bit more detail. But it's going to hopefully tell a story to all the members about exactly how much healthcare is costing, where there have been differences, changes, and how well essentially the plans have been at meeting the 200% of Medicare cap for those facilities in DRG facilities. Okay. As we go through this is going to be a lot of detail, a lot of numbers. So, and especially as this might be the first time that some of the members have actually looked at this information, we'll go in detail and try to explain it. But definitely feel free to interrupt, ask questions as we go through. Otherwise, you'll just be listening to me for the next hour and a half, 2 hours, and that might be a little too bit difficult time this afternoon. But what we have is we compare to Medicare. And, Medicare is being used, I think, more and more as a benchmark for rates. While it has been, obviously the payment system for Medicare, it's also being used as essentially a benchmark or reference for different plans. So for Oregon, which was the legislature was essentially a leader in Senate Bill 1067 and marking to 200%. There are other states that have been doing that. Washington just voted across their own 200% of Medicare bill. It's a little bit different in some areas, and we'll go over just kind of highlight some places where it might be a little bit different in some of the relevant slides. But Medicare is being used as a benchmark because it is out there. It's you have publicly available information to price Medicare. CMS has all the information out there. It's being used for, as you can see, those different plans, and it's a lot of different reporting, especially based on the Oregon 200%. There's definitely other research organizations using Medicare to essentially price out services and to compare how much services cost across the country. Okay, next slide. So what we do, thanks. So as Margaret mentioned, Senate Bill 1067 essentially permeates through IWG and this report because it did establish payment levels, 200% of Medicare for DRG facilities for in-network, if they were in-network. But if you were out-of-network, the payments levels at the maximum would be 185. So those were the limits on the payments. As we take a look at it, there were definitely some services below. There were a lot of services above, especially on the outpatient services. And that did result in savings for OEB and PEB once this bill came in. But as you'll take a look in, or if you've read the report, there are, some of those savings might be eroding a little bit as payments have been going higher recently. There are facilities that are exempt, rural critical access hospitals, certain hospitals in counties with low populations, and sole community hospitals. So there are definitely some exemptions to this bill, but there are 23 hospitals currently in the state that meet the criteria. We have actually 24 in the data that we're going to show on the next few slides, but Peace Health University District closed. So that hospital no longer is open. And so, it's no longer subject to the DRG, the payment requirement. But we are looking at hospitals for 22 and 23 to compare in this next section. Okay, any questions or comments? Okay, so we do have this list here of the hospitals that are subject to 1067. So as mentioned before, there are 24 listed. These names are kind of like a little bit more of the historical names. Some of them have changed a little bit based on new affiliations. Tualatin Community Hospital is now called Hillsborough Medical Center, and there's a few others that may have changed names slightly, but this is the list of hospitals essentially in this next section that we're talking about. Next slide, please. Before we get into numbers, we're going to talk a little bit about the methodology, and this may be a little bit more for the health plans and others who are on this call, just to kind of level set on exactly how this is done. So what was done was actually OEB and PEB currently use a database vendor to manage their claims. And that is Meritive. You may have heard of them. They may have been mentioned in some of the meetings, but Meritive essentially takes the claims from the plans and essentially puts into a database. Meritive subcontracts with a actuarial consulting firm, Wakely, that does Medicare repricing. And so as part of that relationship, Wakely repriced the claims that you're going to see here today. And their methodology, there isn't a whole lot of detail, but there is some detail up there on inpatient and outpatient repricing. So for the inpatient, they did use the IPPS, the Medicare Inpatient Prospective Payment System. To price. There's also inpatient psychiatric pricing for inpatient, but we actually exclude those claims from this analysis. They took the DRGs, MSDRGs that were provided by Meritive and used that to price out essentially the Medicare allowed amounts. There are some DRGs, I think, especially with MODA, some DRGs that may have been priced differently by the plans versus what Wakely priced. And so we are going back and forth on some of those just to make sure, see where they're different. So there are some differences that the plans have noted in some of these payments, but in general, I think, they're pretty close to what they're reporting. And you can kind of compare this to what they self-reported in the second portion of this section of this report. For outpatient, talking about the different outpatient OPPS outpatient prospective payment systems that were used, and some of the information there. It was done by year, so 22 data or 22 pricing for the facilities and the claims, and the weights were used, 23 for 23 weights. So they are time specific and hopefully, as accurate as can be. Okay. Okay. Moving on to the next section. So this is the slide that essentially shows combined inpatient and outpatient for the Senate Bill 1067 facilities. So Senate Bill 1067 says, the bill itself says that claims may not be above the 200% of Medicare for facilities subject to the bill for inpatient or outpatient services. Professional services are not included, but all other services in the facility are. The rules in terms of how it's being interpreted is to take a look at payments by hospital by plan. So while the bill itself specifically says 200% of each claim, the threshold to measure against is the amount above or below for each hospital in total. So there may be some claims that are above 200% of Medicare, and there's some claims that are below 200% of Medicare. But if in aggregate it's below 200% Medicare for the hospital, it meets the threshold. That's the rules say for the Senate Bill 1067 payments. Excuse me. Okay, so that's kind of like the ground rules of this. So what we did was to take a look at Plan Year 22, and that's at the top, and Plan Year 23, and that's at the bottom. So we do have 5 rows. So the total claims that we analyzed, and this is the allowed costs, and that's in millions. And then we show the allowed as a percent of Medicare. So for comparison, just for your reference, thank you. So just for your reference, the OEB and PEB in totals, they're on the left, about $388.8 million in 22. The analysis based on the weekly percentage of Medicare ends up being 185%. So that 388.9 million is actually below the 200% of Medicare in total for inpatient and outpatient. Margaret, had a comment, question?
Yeah, just a quick kind of context setting. So, and I've talked to a number of other states about this policy, this payment cap. I hear regularly. It is the most common question I get from our state partners when I talk to folks from other state employee benefit plans out there across the country. And Emory, historically, when we look at that total amount spent on at the 1067 hospitals, it has been in the neighborhood of about, am I right in saying about 65% of OEB-PEB hospital utilization is happening in those capped facilities?
Yes, and that's
Okay.
that's hospital utilization. So this inpatient and outpatient hospitals. So it's not the full total cost. I mean, because you have professional and other services and pharmacy. But yes, it is. That's in that ballpark. Yes.
Yeah. So just in terms of context, about 35% of our hospital utilization is happening in facilities, either other facilities in the state or facilities outside of Oregon that are not under this payment limit. Yeah. Okay. Thank you.
Yeah. Yes. Thanks, Margaret. Yeah. So it's a large proportion of the OEB and PEB facility cost, but it's not the totality of it. There are definitely, rural hospitals. Those payments tend to be higher, and you will see that in the following slides in the following presentation. Yeah. So this is a big chunk. I think it did save both OEB and PEB in the neighborhood of 80 to 90 million. I think the first year, somewhere in that ballpark.
Yeah, it came in roughly 160 million over the first 2 years, and higher in year 2 than it was in year 1.
Yeah, so there are definitely some savings from it. So as you can, I guess, compare against the 400 million roughly, that's total. So it was definitely a big chunk of savings as a result of the Senate bill and the 200% cap. But so overall total about 389 million. You can see You can see OWEB in the middle section there. So about 175 million, the majority of which is in MODA versus Kaiser. And then you have PEB on the other side, which is a little bit higher at 214 million for 22. And most of it's in Providence, and that is Providence, Choice, and statewide combined. And then you have MODA and Kaiser with their totals. But if you take a look at that, allowed as a percent of Medicare is below 200% across the board for inpatient and outpatient combined. So overall, it is meeting that 200% threshold. But the next section, payments over 200% of Medicare by claim, and I think the by claim is kind of missing there, or hidden based on the formatting, but it's not all claims are meeting that threshold. There are definitely claims that have been above 200% of Medicare. There's more that's below 200% of Medicare, and therefore it's, you're getting at the 185% overall. But there are definitely about 12 million for OEB and 10 million for PEB that are on specific claims themselves that are above the 200% of Medicare. And you can see the percentages down below. So it's about 7% for OEB and about 5% for PEP. But the row at the bottom, so the payments over 200% of Medicare by hospital, this is how the test is for the bill. So basically, again, the total amount of payments for by hospital, by plan, are they above or below 200%? Generally, it is basically meeting. There are very small amounts for most hospitals. There's only a small handful that are above to 200%. Most of them are small amounts. The one you can see MODA has the biggest, but we are going back and forth on that. I think based on some of the DRGs and also based on the way the claims were being, reported, we think there might be some issues with some claims that weren't actually subject to the 200% being listed as being subject to 200%. And so we're working on identifying those claims. So we'll talk with MODA and make sure that we get the right number there to make sure that they are beating that 200%. But we do think there is like a data issue that's like confounding these results. But overall, as mentioned before, if you essentially ignore or take out most of that MODA amounts, the claims are meeting that 200% of Medicare in 22. Okay. And then down below, you can see 23. The total dollars are higher, 420 million. And each OEB and PEB both had increases in the amounts at these facilities subject to 1067. The percentage on average, again, is 185. A little bit changes depending on which plan that you're looking at in the OEB and PEB, but generally pretty consistent in this reporting. The dollars that are above by claim are in that middle section are very similar to what was reported in 22, so not drastically different. And then the payments over 200% Medicare by hospital, again, a very similar story. It's actually a little bit better performance compared to 200% Medicare in 23 based on the data. And again, that MODA issue still, I think, permeates in that number. So that 0.7 is probably not truly 0.7. But like I said, overall, it's meeting 200%, but it has been increasing. The 2021% of Medicare, based on the work that Willis Towers did previously, was 163. So it has been increasing. And as we take a look at the historical information in some of the other slides later on, you will see it has been increasing over the past few years. Any questions or comments on this slide? I know that's a lot of numbers. Just want to make sure everyone understands what we're looking at. So if you have any questions on understanding, please ask me if I did not explain it well. Okay. All right. Next slide. So the next two slides just split out inpatient and outpatient. So inpatient only, the information is provided at a similar level. So similar kind of information. It's by admission. In this case, plan year 22 is at the top, plan year 23 is at the bottom. I guess the subheader reimbursements were at 150% of Medicare in the prior analysis. Now it's about 178. Overall, again, generally meeting that 200% of Medicare. There are, I think, a little bit more dollars on by admission that are above the 200% compared to in total. But when you take a look at the loudest percentage of Medicare, it's 178 for both of these. The prior slide had 180. Can't even remember. It was a little bit higher. So inpatient costs have been lower. There are some services, especially like maternity, that tends to be lower as a percentage of Medicare. And so that does bring down this overall number. Okay. Next slide. Outpatient. So for outpatient, the number is much, much closer to 200%. You can see that some plans, as loud as a percentage of Medicare, are essentially bumping up or actually at 200%. So for OEB, it's at 199 in total, with MODA at 200 and Kaiser at 196. PEB's a little bit lower at 192, with Providence at 190, while MODA and Kaiser are a bit higher. That said, the payments over 200% of Medicare is actually a little bit smaller, especially as a percentage by claim. So there's more adherence by claim in this case to the 200% threshold. The payments over 200% of Medicare by hospital, again, MODA's the one that's kind of an outlier, and that's where we have the questions. I think it's just showing up in this data, but it may not be nearly to that extent when we actually finally work through all of the underlying data questions there. And in the BOM section for 23, it's 196%. As you can see in the subheader, it's increased from 179 in 2021. And again, MODA is above 200%, but that's again probably because of the hospital issue and the claims. So generally, they are meeting the 200% threshold in this case. So this is this is information we wanted to show to see how each plan was performing its 200% threshold for these facilities. I think to me the story is yes, generally they are meeting, although the costs are like I said before, they have been increasing. You can take a look at some of the services and the gap between what they were being paid at previously and 200% has been decreasing, and I think it's going to be a little bit more noticeable in the next presentation, next few slides. So any questions or comments? Yes, Mark.
Yeah, Emery, I just wanted to note in terms of follow-up related to this, so there are some questions in process related to some specific cases in the data. So we're working to reconcile those discrepancies. And I will flag on the work group agenda for the next meeting in early fall a follow-up, just so that we can come back and report back on the resolution of all those questions that are still in process. And truly, when we call this review a compliance verification because it's not a full claims audit. The word audit has a really kind of specific meaning. But I think that really that sort of a situation is really the point of this compliance verification, is to look at where the claims are coming in overall and then identify where we need to drill down and do some further data vetting. So thank you, Emery, for all that information, and we will include a follow-up on the work still in process for the next meeting agenda.
Thanks. Okay. With that, let's move to the next slide. Okay. So taking a look at the level of payment. So this is a report that we request or require the plans for OEB and PEB to provide. This is self-reported information on provider reimbursement relative to Medicare. So it's basically taking a look at a bigger subset of claims, very similar information to what we just showed before. So taking the loud claims, repricing it, and just on Medicare, and then seeing what the percentage, how much what percent of Medicare are the services for these different categories. So we do look at different additional categories here. So the top two, inpatient and outpatient hospitals, so that was essentially the information I was shown before, but we do also include those that are not DRG facilities and potentially outside of Oregon. So Washington, Idaho, California, other states where services are included, they are have been performed, those would be included, and they would be put into the exempted from payment cap section. The hospitals impacted by the cap would be essentially that subset of Senate Bills 1067, and then exempted is essentially every other facility, including those who are rural hospitals or those not specifically excluded from the 1067 bill. We also have other subsets. So we do take a look at ambulatory surgical centers, ASCs, independent facilities, take a look at different physician services, ambulance, and some other services, including like medical pharmacy. And so overall, this does represent a much bigger subset of the OEB and PEB costs and provides I guess, a more global look at how each plan is paying as a percent of Medicare, and also gives some information as to the underlying unit cost of those plans. So you can use it to kind of really compare against each plan against each other. I think it is kind of illuminative, less illuminative. It does give you good information about the underlying costs and may help, raise some questions or give you some understanding as to why renewal results have been the way they have. The renewal results have been, the way they have been, and how claims have been changing over time. So that's the type of information that we're going to be showing in the next few slides. Next slide, please. Okay, so what was provided? So each plan provided information, again, those different sections, based on allowed dollars and 100% of Medicare. Not all service categories were provided by all the plans. Most of them, they've gotten better, and most of the service categories are being provided for outpatient hospital. MODA only supplied overall, and Kaiser also did supply overall percent of Medicare, but did give us the different dollars for the different sections of each services. So not as much detail for outpatient hospitals for MODA and Kaiser compared to Providence. Different information for independent facilities and physicians. The one line there down below, Kaiser integrated care fees, management fees. So they were not included by Kaiser as part of the reimbursement level. They are considered as claims when Kaiser does their renewal rating. They are trended at claims depending on the integrated care management fee category. Some are based on a per member cost. Some are based on a per claim portion of the claims. And so those are additional costs that show up in the claims and are not part of the retention, but they're not included as part of this reimbursement level. So if you're trying to do a comparison of the overall cost of services based on the percentages here, I would say, you should probably include integrated care management fees in that when you're looking through some of this information. If you just take a look at the administrative fees, they're kind of like the retention administrative fees are kind of a little bit more equal across the plans. But Kaiser does include integrated care management fees that aren't really part of this report. That's above and beyond just the retention. That's part of the renewal report, renewal ratings. Okay, next slide, please. So this is a summary of the overall reimbursement. So this is comparison of the different plans. So you have Kaiser on the left, MODA in the middle, and Providence on the right. OWEB is in blue or on the left. PEB is in green or on the right. So comparing the different plans, so Kaiser on the left, we can go through that. So 23 is on the left. For OWEB, it was 192% of Medicare overall for the data that was provided, 191 for PEB. So that is an increase over 22 and 21. 22, you can see that OWEB was 183% and PEB was 179%. So this is a comparison against Medicare. So you see the increases, in terms of the percentage increases, 4 or 5 or more percent for the percentage of Medicare increase. What also is not included here is the level that Medicare increased. So Medicare does increase by year roughly 3%, 4% maybe. So on top of these percentage increases, you have to, if you're trying to take a look at the underlying cost increases, you have to include that Medicare underlying unit cost increase as well. MODA's in the middle section. So MODA was at 187 in 23 for OEB and 175 for PEB. In 22, MODA was at 179 for OEB and 169 for PEB. So again, an increase in the percentage of Medicare from 22 to 23. MODA's OEB percentage reimbursement is different than PEB's. The networks are a bit different. PEB only essentially has the Synergy network. There is a PPO network for OEB, and so the reimbursement levels are a little bit different across that. So that's the reason why OEB is higher than PEB. And then Providence, they're on the right for PEB. There is an increase, but it's more consistent, more steady. 187 overall in 23 versus 185 for Providence in 22. So generally, I guess, Providence has been pretty steady. MODA's increased, at least for OEB, reaches the Providence level, although it's lower for PEB. And then Kaiser now is above both MODA and Providence in terms of the overall reimbursement levels. Any questions or comments? Okay. So next slide. So this is another look at the information. Taking a look at the overall reimbursement by plan, this is 23. As mentioned earlier, the integrated care management fees are not included in the Kaiser information. So the ICM fees are essentially that blue slashes. Go ahead, Margaret.
I'm going to take my hand down. The blue slashes just answered my question. Thank you, Emery.
Yes. Okay. So what we wanted to do was show the impact of the integrated care management fees, because as mentioned earlier, the retention or the admin fees, that's kind of similar across the board. They are different, but they're more similar. And these integrated care management fees, you can see, would be another 30 points on top of OEB and 28 for PEB. And so if you include those care management fees, you can see Kaiser's reimbursement levels for each claim essentially is, significantly higher than MODA and Providence. And if you do compare that, it is above 200%, in terms of the fees. And then, so it is higher overall when you take a look at the level payment. Yes, Robert.
Yes. What takeaway for somebody like me on the differences between MODA and Kaiser on this graph?
Yeah, so basically it's like if you're going to ask, if you were to ask me the underlying unit cost of the plans, how would you compare them, in terms of like for a service, like a hospital admit or for like a doctor's visit, how would you compare the prices for each of these plans in terms of their contracting or what gets charged? And so what I would say is, okay, so for me, MODA actually ends up being maybe the lowest cost. They are definitely lowest cost for PEB, and they're lower cost than Kaiser for OEB. And that when you want to compare the true underlying costs between Kaiser and MODA, so you would need to compare that 222 versus the 187 for OEB. And so that percentage difference, which 35, so we're talking almost 20% difference, is really the underlying cost difference of those plans for just purely the unit cost.
Sure, this is way too simplistic, but is the difference, at least part of it, attributable to Kaiser owning their own hospital system and MODA not, or is there some other explanation?
That's a good question. I think Kaiser does essentially set their own rates. And so the underlying fees and integrated care management fees, they set those as part of the renewal rates, and that that's what you accept as you accept their premium offering. And so so they are setting their own rates. Whether that's the reason why this is higher, I think there's more things that we need to talk about, that it's not that simple. But I mean, they do set their own rates and they are higher. And I think that is, I don't know, at least when I take a look at the efficiency, I take out the risk adjustment, I take a look at just the underlying cost of the plans. This sort of delta does show up for PEB. And so I do believe that some of it has to do with the unit cost differences in terms of how they're not necessarily showing up as efficient on a dollar basis. They do, talk about their integrated care, that they're a, integrated system, and that should show up in better care, better outcomes, and hopefully better efficiency. It's, I mean, we're asking for 20% efficiency, because if we're looking purely at cost because of the unit cost difference, and that's a pretty high bar to meet. Garner, that's being included for OEB. PEB's talking about it. Garner, takes a look at the top providers and the efficiency. One of the clients from Mercer put Garner essentially as the network, and that got 17% savings. 17% is still, that's a lot of savings, but it's not quite this 20% delta. So it's a high mark to reach in terms of efficiency, to make up the unit cost difference. Robert? Okay. Any other questions or comments? Go ahead, Sal.
Just comparing the Kaiser and Moda, I'm wondering if also Kaiser costs are higher because there are services that are covered under a copay and not co-insurance more than with Moda. So there's some higher cost or higher coverage, right, for certain things with Kaiser, and I think that obviously comes with a higher cost. So less of the cost ends up with the member under Kaiser than with Moda.
You are correct. I think Kaiser does have a lot more copay plans. I mean, with PEB, there's no deductible in one of the plans, and and the cost sharing is definitely a lot less in Kaiser than it is under Moda, especially when you're talking about high deductible plans. But we are looking on a allowed basis, so this isn't on a paid basis. So this is on essentially before any member cost sharing gets applied. So this is really just the underlying cost of the service or the contracts, essentially.
Okay, thank you.
Okay, next slide, please. So the next few slides, we will be going over the various categories of service. So you can see where the differences lie. Comparison, against that essentially 190, 185, 190% on average. So you can see where some services are more expensive than others, as well as taking a look at the different plans. And so just kind of as you're going in mind, that 185 threshold is roughly on average what you should say is like overall. These next slides do not include the Kaiser integrated care management fees, so it's just what Kaiser self-reported. Adding that additional integrated care management fees will get a little bit more at the true underlying cost for Kaiser. But what we see here are the hospital costs. So we do break out inpatient and outpatient. So inpatients on the left, outpatients on the right. And we have those subject to 1067. So essentially the information that we had showed before on the left and exempt on the right. So the far left is subject to 1067. So those DRG facilities, inpatient. costs. So overall, they are, 170-ish, 157 for MODA for PEPs, like the low one, Providence is at 177 for PEP, and that's the higher one. But overall, they're kind of in that threshold and, below the 200% in this case. The exempt facilities for inpatient hospitals. So for Kaiser, it's definitely a smaller portion, 2%. For MODA and Providence, it's a bit higher, 15 and 20% of the services are at the exempt facilities for inpatient. The levels are actually pretty good, especially compared to Senate Bill 1067. So it's below for Kaiser and MODA, below what they have for the subject to 1067. But Providence is at 200%. So the Providence exempt is a bit higher. Margaret.
Yeah, so on those exempt inpatient hospitals, the way I think about those is that so there's a mix. Those are going to include some DRG hospitals that are located out of state. It's also going to include hospitals that are not paid under DRGs by Medicare. So, for example, like rural hospitals that Medicare pays cost plus. So because their payment methodology under Medicare is so different, the fact that, like, let's say, for example, they're showing at like 139 or 143% of Medicare doesn't actually mean that, like, on a dollar basis, they are paid better than the facilities subject to the cap. I'm trying to sort of reconcile that, like, when you look at the facilities subject to the hospital cap, and then you look at the exempt facilities next to them, it looks like one could interpret this to say, oh, are we actually paying less to the exempt facilities? And I just want to call out, I think, there's a Medicare methodology difference related to the exempt. So this is a little bit of apples and oranges, because if Medicare is already paying those exempt facilities cost plus, double their cost plus a margin would be a lot more than say 200% of a DRG in theory. So I just kind of want to call that out, because I think that's an important clarification when you look at the two side by side, and just hoping you can either confirm or correct kind of what I've stated.
No, I think, I can't state with 100% certainty, but yes, I think you are, I would agree with you. We will be also taking a look at hospital payments a little bit more detail. We do like a hospital payment analysis report. And so we will take a look at more of that in detail to show, like, really true, like, what's the cost for certain services for certain admits by different facilities. And we will, highlight that, especially with our data that has percent of Medicare as well. So we can do that comparison to verify what you're stating, Margaret.
Okay, thank you.
Yeah. For outpatient hospital, the services are for those subject to 1067, similar to what we showed for the first part of this report. They are essentially bumping up against 200%. And so there is pretty good consistency between what was reported and what our Mercer's analysis showed. For the exempt facilities, you can see that the payments are significantly higher, about 235 to 280. Historically, before Senate Bill 1067, the DRG facilities were getting paid about 260-ish percent of Medicare for outpatient services. So it did drop quite significantly, and that's where the majority of the savings came from Senate Bill 1067. So overall, for outpatient hospital, since they were above, they all kind of went to the 200% threshold and have kind of stayed at that level since. The inpatient hospital, actually, let's move to the next slide. The inpatient hospitals, this is comparison to prior. Inpatient hospitals have, subject to 1067, have kind of that, have gone up a little bit. So Kaiser is the top, MODA's in the middle in purple, and Providence is on the bottom. So the far left are the inpatient services subject to the 1067, so subject to the DRG facilities. So we have the 23 on the left and the 22 on the right. And so you can see, for both MODA and Kaiser, the percentage of Medicare has been going up. So it's gone up from 166 to 169 for OEB for Kaiser and 161 to 167 for PEB. And then MODA, same kind of similar story, 167 to 170 for OEB versus 153 and 157 for PEB. So overall, Kaiser and MODA's inpatient DRG facility costs are going up as a percentage of Medicare. On the outpatient, for Providence, it's actually kind of flat at 177. But for outpatient, those are the two right-hand columns. So taking a look at the subject to 1067, they are, for Kaiser, it's kind of bumping up, increased from about 190 to 197. And similar story again for MODA, from about 192 basically up to 200%. So, so that whatever savings or whatever amounts below the 200%, that is eroding, disappearing. They are getting closer to 200%, especially for outpatient, and that is part of the reason why I think, it's underlying contract costs, and part of the reason why, some of the renewal results recently, claims recently have been going up. Any questions or comments? Okay. Next slide. So taking a look at professional services, we did break out some different types of services. So you have primary care or PCP there on the left. We have specialists, including the PT, OT, but they don't include surgery, anesthesia, or maternity. So those are basically all other professional services in that second column. So, so color coding, similar to other slides. So Kaiser is in blue, MODA's in purple, and Providence is in essentially red. The slanted lines, the solid bars are OEB, and then the slanted lines are PEB. So you can kind of compare where the professional services are. I think generally the story for me, at least, is that Kaiser, again, tends to be higher. Except for the specialist, including PT, OT, ST, but surgical costs are higher. Anesthesia and maternity as well tend to be higher. The primary care is pretty close to Providence, but definitely higher than what MODIS is paying on a percentage of Medicare. And once again, integrated care management fees aren't included. So you kind of have to tack on the integrated care management fees for the true overall cost for each of these services under Kaiser. Anesthesia tends to be a very high paid service, and so that 380 is not, or 300% is not unexpected, but it tends to be high. Okay, the next slide will show the history. So again, kind of taking a look at the different plans, Kaiser at the top, MODA in the middle, and then Providence at the bottom. So really kind of comparing the changes from current to prior to current for the different plans. Again, the coding's kind of the same. Honestly, I guess for MODA and Kaiser, the story's kind of similar. It has been going up by, I don't know, a decent amount as a percentage of Medicare. For Providence, it's gone up as well a little bit. So primary care has increased quite a bit, specialist as well. Surgical's about the same. Maternity's gone up, but overall, professional services, what they're getting paid as a percentage of Medicare has been increasing. One note, Senate Bill 1067 did not talk about physician services. Those were just being paid as they're being paid. In Washington, with the bill that capped facilities at 200% of Medicare, they have a couple of clauses in there for primary care services as well as behavioral health. They put in a minimum payment as a percentage of Medicare, and that's 150%. So as you can see here, primary care is above the 150% for Oregon, at least Kaiser, MODA, and Providence. But in Washington, they did put in that floor for primary care services. Okay, next slide. Medical pharmacy. So this slide does shows medical pharmacy, essentially those specialty drugs that are provided either in a facility, outpatient facility, or a physician's office. So we do show outpatient hospitals here between those subject to 1067, those exempt from 1067, and then the services performed in the office physician service. MODA was not able to provide outpatient. They did provide office physician. So you're seeing that there's a gap there. So we don't have that data. Um, so, so what you see, medical pharmacy, you have the drug prices, and then there's essentially a dispensing fee, and then whatever is based on the contracted rates. So, in many ways, it's a little bit of a commodity, and with commodities, and there's the physician administering, which and the storage, so there's additional cost for that, but it's essentially a commodity, and what Medicare pays essentially is pretty close to wholesale price, what is the market price. So we would expect this to be closer to 100%. I think, this is one area where it seems like, going to 100% would be a little bit, be more reflective of the true cost of these services. There is a situation for PEB where there was a CAR-T therapy that was performed. The hospital was a Senate Bill 1067 hospital. They declined to do a special case rate, and they essentially got 200%. So they got double the list price for that service. And considering the service is like $500,000, that's just, $500,000 extra dollars that was paid out in that case. So in terms of contracting, Kimberly, for the RFP, this is one area that we are focusing on because we don't want to have situations like that where potentially, payments are being higher than essentially what you could get. Medicare is getting significantly higher without that. I mean, it's just one area where there's maybe some inefficiencies that can be maybe worked on for the RFP. But generally, yeah, so it's like you can see office physician is lower, closer to that 100% level, but outpatient is higher. There is, for Kaiser, there's not that much in the outpatient, and we'll show combined on the next slide. Sally.
Do we expect that MODA will provide us that information? Is it that they couldn't provide it in time, or they can't provide it at all?
It's something that's been historical. I think we've asked for them to provide it. I'll have to look at the exact reason why it was like they were not able to provide it. But we can just ask them again to see if they can take another look at it.
Okay.
Okay, so this next slide kind of combines all of those locations together. And yeah, Enrique, go ahead. Sorry,
You're on mute.
I can't hear you. I don't know if you're on double mute. You want to type your question in the chat box? Okay. While you're doing that, let me just kind of go over the slide kind of quickly. So this takes the prior information and kind of combines it all together. So overall medical pharmacy, how much is being paid as a percentage of Medicare. So for Kaiser, you can see that on the top left, they're about 160, has increased from last year. MODA, because the information they have is just office, it's a little bit lower, it's 118, and Providence combines about 134. So generally, Kaiser is higher again, higher than Providence by like 25%, and that's prior to the integrated care management fees. So the overall cost for this medical pharmacy is definitely high. Enrique, are you able to? Sorry. Okay. All right. We'll come back to this slide when you're able to get your microphone working. Okay, good. Okay, so yeah, so that's medical pharmacy. All right. Anyone else have a question, comment before we move on? Okay, next slide, please. So lab and radiology. These are, the costs for those different types of services. So laboratory services are at the top and radiology is down at the bottom. Again, so we have outpatient hospital. Kaiser did, they provided dollars. We showed the percentages. That's really the overall percentages for those different hospitals. So it's not necessarily a split out of the true underlying cost in those facilities. But if we take a look at over to the right, the lab and radiology for office physicians especially, there is definitely, again, a big kind of delta between some of the plans. Providence is the lowest in both. Lab is about 140, Modus a bit higher, 160, 170. And then you have Kaiser coming in at 220, 230. For those services. The independent facilities, it's kind of flipped, where Kaiser does have very low services for independent or low cost per percent Medicare for independent facilities. For radiology, the amounts are a bit higher if you focus on the two right-hand sides as a percentage of Medicare, but it is, again, kind of the slope is pretty similar, at least for the office physician, where Kaiser is the highest compared to MODA, and Providence is coming in essentially lower, a little bit lower than MODA in this case. For independent facilities, the Providence radiology is a bit higher than MODA. Enrique, any luck? No? Okay. Next slide, which shows a comparison to prior. Overall, I think this is a little bit better story. I think these haven't increased nearly as much, although I think Providence did increase a bit in some of these cases. But overall, they're kind of consistent-ish. I think, again, kind of the outpatient facilities for Kaiser, you kind of disregard that a little bit, take a look more at the office physician. The office physician lab, which is kind of in that middle section for Kaiser, again, they did go up quite a bit versus 2022 versus 23, and then radiology, slight increases there. For MODA, it's a little bit more consistent, where the rates haven't really increased very much. For Providence, the outpatient facility subject did go up a bit. The others are kind of steady in this case. Understood, Sally. Okay. Next slide. Behavioral health. Again, information is provided by Kaiser for independent facilities as well as Providence. Those for Kaiser a little bit higher at 240%. For Providence, it is a bit lower. But office physician, this is where I think most of the services are being performed. This is where I think there's been a lot of work with, especially with the Oregon legislature and Medicaid, to increase those reimbursements, and they have been showing up here in terms of the increases, but they are still relatively low as a percentage of Medicare. As mentioned before, state of Washington did put a floor in of 150%. These obviously are below that. I guess Margaret and I had talked about this as a potential area where we might want to watch out, because if the providers in Oregon who might be licensed in Washington can do services in Washington at a much higher rate than what is currently being paid for by the PEB and OEB plant, will they continue to do that? Will they potentially start shifting their services to get paid more in Washington? I do have some major concerns about that. When Medicaid increased their reimbursement levels, a lot of providers did split out of their group practices because they were doing Medicaid only and they could get paid significantly more. So they started doing like just focusing on Medicaid in that case and moving away from where they might get paid less. So where the money is, they might follow. So this is one area where we do need to be cognizant of potential erosion, especially with behavioral health being, the needs keep going up and up and up, and the providers are not nearly as much, I think, as what's needed. So this is something that we need to watch out for. Data is showing trends in those different services. Yes. So, Enrique, what you're asking there about some of like those different breakouts, that's some reporting that we have done in the past in IWG, where it's the hospital monitoring report, where we try to look at some of the consequences or like how services are being performed by different types of services. So we will focus on those. Yeah, we do look at surgeries, we look at cancer services, mental health services. So we will look at that sort of information. And so we can provide that on a historical basis. But that's a different report that we can provide. Okay. Any other questions before we move on to the next slide? Next slide shows the history where the reimbursements have gone up, most notably for MODA. And I think based on some of the payments and some information we've heard, they continue to go up a bit. So hopefully these numbers in 24 will be a bit higher, especially as the Medicaid reimbursements kind of keep being increased with their directed payments. And it'll be interesting to see the impacts of some of the other direct payments where some of the language capabilities, the culturally and linguistically sensitive services, and some of the other services get paid a bit more. So we'll see how that flows through in the data for the behavioral health services for PEB and OAP. Okay, next slide. So ASCs here, and this is one area where we will do more breakouts based on that payments. So taking a look at the ASCs here, they have increased for Kaiser. They went up from about 214, 220 to 260, 270. But for Province and MODA, they're pretty consistent. So as a percentage of Medicare, I think a lot of the services are a little bit lower in terms of similar services compared to in a hospital or an actual facility. But that's some of the additional data that we will provide, look at in the hospital monitoring report. But overall, I guess Kaiser for MODA and Providence have been pretty steady. Next slide, please. And there's only a couple more. So other services are listed here. Ambulances there on the left. So that does include air and essentially road ambulances, or, so it is a mix, depending on the mix of services, especially for PEB with some of the statewide and area ambulances. Those percentage of Medicare can be definitely a bit higher. But overall, if you're in the ambulance transportation, you do get paid a good bit more than Medicare. DME, so that is another essentially commodity pricing, right? So you have the cost for the specific item. This is one area where Kaiser actually shows up well. So it's lower in terms of the overall payments as a percentage of Medicare, more so than MODA, OEP, and PEB, and then Providence. So DME is closer to 100%, which is good. And then all other, just kind of all other catch-all services there. MODA and Providence are about 120, and Kaiser's a little bit higher, which is kind of, I think, in line with physician services in general. Okay, next slide, please. So that's the breakout of all of the information. We do show different, I guess, mixes. This is all the same information, but packaged a little bit differently in terms of, this is for OEB in this case, and you can compare Kaiser, which is in blue, and MODA in red. So you can take a look at the different levels of service, the different types of services, and where the plans might differ in terms of the reimbursement levels. So it's just the same information. Hospitals are at the top, and then you start getting into those subsets down below. Yeah, so this is kind of the breakout for OEB. PEB's going to be on the next page. And you can definitely look at this, I mean, in the presentation. I know it's kind of small numbers, but it's kind of like just kind of giving you a graphical, kind of quicker look, I believe, at it. Hopefully, it does come through. So kind of, again, the breakouts for different categories. Providence is the third one down below, so you can see where each plan differs. And then we have, next slide. Then we have Kaiser, just kind of like PEB versus OEB, and then MODIS going to be on the next page, PEB versus OEB by the different categories again, and then Providence on the final page. But once again, it's, just kind of different ways of looking at the information that was provided before. Well, actually, let's go 2 more slides, please. Okay. So, key takeaways, I guess, just some things, motor reimbursements, well, kind of lowest percentage of Medicare. Kaiser, are higher, and the ones you see don't include integrated care management fees. And then some other information. I think we've gone over most of this in terms of when we go slide by slide, but it's a lot of things that commodity pricing, it's like hopefully it's, especially drugs where, markups are more pure profit than anything else, or like DME and some other services. Hopefully those, we can work on that to bring those down because it's just additional cost compared to what the market price is. And then it's just, I guess, erosion of potentially services against the 200%. It's continues to go up. We'll see what happens in 24, especially, and 25. I think I'm with the uncertain tariffs, right? The impacts of those on services and inflation and wages. We'll see how that impacts both OEB and PEB. But as a percentage of Medicare, it's going up. And if Medicare is going up by 3%, each percent of Medicare, each delta, each increase in the points versus Medicare is just making it that much harder to meet the 3.4%. And so, as OEB and PEB have kind of struggled to meet the 3.4% over the last few years, it's kind of, it looks like underlying that is a lot of unit cost. And so that has been maybe a big driver and part of the reasons what's been going on. With that, I think that's actually the presentation. Are there any questions or comments from any members? Or Margaret?
No, thanks, Emery. I do think it would be great for this work group to consider. I mean, of course, some of the things that stand out are like, some of the categories like anesthesia and ambulance, where they're consistently multiples of Medicare. And it makes me wonder, are there opportunities to dig more deeply into those specific areas of services? I know depending on who you talk to out there in the ecosystem, some will say, well, Medicare does a better job with rates for certain things versus other things. You know, there's certainly a lot of complexity there, but I'm just wondering if there are particular areas that we should really be targeting in terms of contracting best practices, or, I mean, again, I go back to centers of excellence. Of course, ambulance and anesthesia don't really lend themselves to a center of excellence. But it really makes me want to ponder what the opportunities are. I mean, starting, outliers are sometimes a good place to start. And so getting into like, are these in fact outliers, and what are the other outliers we should be focused on? I do want to acknowledge a couple of comments from the board and work group members on. Sally's noting that she would really like to circle back to this later with more comprehensive data from MODA. And the good thing is this is a recurring report for the work group, so we'll certainly be updating it with another refresh of data down the road in the near future, and can work to make sure that's comprehensive. And then acknowledging Enrique's request around looking at how utilization is trending. And I think that's definitely something that we can add to the fall meeting agenda for a fall work group meeting.
Yes, definitely. Yeah, Margaret, I mean, there are definitely ways. I mean, that one thing that kind of strikes me is, OEB with their reference-based pricing for some services for like bariatric and I think knee, where the rates were set and the hospitals went down to those rates. If those sorts of things seem to work, setting rates, but it'd be interesting. I think with Garner, they are talking not just about it's efficiency, but it's efficiency on cost and services, and so it'll be interesting to see the impact of that as well. And we'll see how well. It's going to be a little bit more time before we get the information, but it'd be interesting to see how that impacts the percent of Medicare. If these providers are the ones who are like better contracting or just better users of services, better management of those services. And if that's the case, we might not see the percentage of Medicare go down. It's just like, but the overall cost will go down. And so that'll be interesting to note in a couple of years when the data starts flowing through in this case. But there's definitely a lot of things that can work. We can work on to try to improve management, like oversight of these things and ways to improve. James.
You already mentioned it here and there a few times, but I do think after watching the presentation, there is a general theme that when we set the 200% of Medicare cap, there were some admissions, DRGs that were below and some were above. The above came down, the below have been coming up. So we are losing ground as the providers or plans are pressured to accept higher rates when they can, because sometimes they can't. The other thing I just thought as we were going through and with all of our different trend and inflation challenges, every time we lose ground relative to Medicare by 3, 4, 5, 6%, and Medicare is increasing by 3 or 4%, pretty soon we're at a 10% unit cost trend. So I guess this is just another perspective on the inflationary pressures that are really ruling our lives right now.
And Margaret had made a note to James. So for those who don't know James, if you're on the PEB side, you'd probably know him pretty well. James Matheson is what I call an actuary emeritus. He's an actuary. Has been working on the PEB plan for quite a while and working with IWG since its inception. So James, thank you for joining and providing your insights. And we work closely together on these reports and providing information for the IWG.
And Emery, that was one of the things I was struck by with your report is I remember when this all came down and it's like, boy, we're just rising to the 200 or surpassing in many cases. But yeah. And it's all very expensive, very, very expensive.
Yes.
Rose, did we have any public comment?
No public comment.
Okay. Did anybody else have any good Enrique, let's see what we got here. Well, that's a Mercer question, isn't it, Margaret?
That's a big question. We will talk that over with staff and try to come up with game plan for that. But yeah, we will. Yeah, I mean, let's capture that too and try to see what information we can get on that, as well as your question, I think, on, what is the reason for the contracting, or the reason why the rates are going up, and getting a little bit of information from the plans on that. I think Robert had his question on that as well, so we can try to get some more information.
I think we had an excellent turnout for today's meeting, and it's wonderful that we're all back together again. And I've got some big shoes to fill, but I'm happy to be here for all of you. And Margaret, you're just so gracious, such a good cheerleader behind the scenes and helper. So Mercer, thank you. And Margaret, did you have anything for the wrap up?
No, just that we will be in touch offline to get those fall meetings on the calendar, and staff will be fleshing out the work plan and the topics and probably sharing that with all of you, via email in the coming months, so that you sort of have a heads up as to what the plan is, and then really reconvening in earnest in the fall.
Fantastic. Ali, did you have anything for us?
No, just wanted to thank everyone. Like you said, it was a really great turnout, and it's really exciting to get the IWG back running again. And I think it was asked earlier to differentiate from CIAO, and I really think the IWG, has said future focused, how to best leverage PEB and OEB's purchasing power and data to really look at some joint strategies, where CIAO is a little bit more plan management, plan design, more in the moment kind of initiatives that the boards are looking at. So, and great presentation. Thank you.
Thank you. Well, I think that's what we have for today. And thank you all for attending. And thank you, Mercer, for presentation. And thank you, Margaret, and everybody for being here. And have a good summer, because we won't see you till the fall. So have a good summer. And Sally, welcome. We're so glad to have you. And of course, Robert and everybody that was here, thank you so much. And have a good summer. Thank you.
Good.